Good morning, everybody. Lovely to see you. So, some of you might have seen me before. I'm Nigel Denby. I am the menopause dietitian, and I am just waiting for Dr. Menopause Care, aka Naomi Potter, Dr. Naomi Potter, to join me. Because we're with you this morning to talk about perimenopause, who it affects, when you know you're in it, what you might expect to experience, when it's likely to happen. I can see Dr. Potter is around. I'm going to see if I can get her to join us just now. Anyway, here she is. Hello, Supergirl. How are you?
I'm good, thank you. How are you?
I'm really good, thank you. Better for seeing you.
Oh, you too, Nigel, as always.
I was just talking to the folk that are joining and saying this is kind of us getting back together again to...
Reunited.
Exactly. I think it is the cue for a song, but maybe it's a little bit early in the day for that. But yeah, to kind of get back to basics a little bit and start thinking about perimenopause. And I think let's just really pull it apart and put it all back together again, to just give some clarity, because I've been reading so much garbage just lately that I think it must be dead confusing for women that are thinking about this. So reason I've been asking people all week on my page and on my Facebook page, Harley Street at Home. They've been sending me in questions all week. So do you mind if I kind of fire all those questions at you?
Go for it. No, go
Brilliant.
for
it. And then obviously if the guys watching have got questions as well, I'll keep an eye on all of those. So you just concentrate on sharing knowledge and expertise and I'll kind of feed the questions. But
Brilliant.
I mean, exactly what is perimenopause? Why is it different from menopause?
It's funny, isn't it? It's a term that probably wasn't even around, 10 or 15 or 20 years ago. It just wasn't heard of. It does seem to have crept into the vocabulary more recently than just the menopause. So really, as time goes on for a woman, her ovaries function less well. And by the time you're in your 40s, even your early 40s, they will definitely be functioning less well and producing less estrogen. So the menopause is not a line in the sand. It used to be that you were either premenopausal, before your periods had stopped, or postmenopausal, after your periods had stopped. Whereas now we realise that women get symptoms for a long time before their periods actually stop. And even when they're having regular periods, they can still have these perimenopausal symptoms that arise from this decreasing or fluctuating estrogen.
So yeah, so does premenopause, is that even a term we use anymore?
So if you are premenopausal, you would be, somebody who was in your 30s or a younger woman with no symptoms of estrogen deficiency. And then I think once you've developed symptoms of estrogen deficiency, then you would be a kind of perimenopausal.
Gotcha. Okay.
And those symptoms don't have to be changing periods. They can be all sorts of other symptoms. The less classic symptoms, for example.
So essentially we could be saying perimenopause is the presence of symptoms rather than the absence of periods.
Yes, absolutely. Yeah.
Right. Okay. So then let's start thinking about symptoms, because I'm getting women often saying to me, yeah, I'm a long way off menopause because I'm still getting regular periods. And that's absolutely right. Then you can be very perimenopausal and still have regular as clockwork
And
periods.
they're the really tricky group, because they're the ones that go to their doctors and say, look, I've got these symptoms, I don't know what they are. And you do and they've got regular periods, so the doctor doesn't even necessarily think that the menopause could be the culprit. They do all sorts of bloods and they all come back normal. And that's when women start to feel like they're losing their marbles, because they've got no concrete evidence that there's anything going on, that there's anything wrong, and yet they feel awful.
And so, right, how might they feel awful? Because I think this is what will start ringing bells.
Yeah, so the problem with menopause or perimenopause is that estrogen basically affects practically every organ system. I cannot think of anything that it does not affect in one way or another. And so because it affects every organ system, a deficiency of it can also affect every organ system. And literally, it's from the top of your head. I say this a lot, from the top of your head to the tips of your toes, because so if we work that way, you can get hair loss, skin changes, dry eyes, dry nose, mouth issues, burning tongue, tingling, tinnitus, chest pain, palpitations, upset tummy, constipation, IBS. Periods changing, periods not changing, getting heavier, getting lighter, vaginal symptoms, soreness, itch, burn, urinary symptoms, muscle pain, stiffness, joint pain, joint stiffness, weight gain. We've got brain fog, anxiety, depression. Oh yeah, I mean,
Wow.
I don't know. I'm sure I would have missed
I
some.
was just thinking further down, sort of restless leg syndrome. Oh, gosh. I mean, I'm talking like I've got menopause, but I'm in menopause, but I get restless legs and it drives me absolutely loopy. So, right. So all of these, I mean, as far as I'm aware, these symptoms rarely hit, all symptoms rarely hit one woman.
I think you'd be pretty unlucky to have every single one, but you can do.
And would you normally expect women to present with, or someone's just said shortness of breath and pins and needles? Definitely, yeah. But would you normally expect someone to present with symptoms isolated to one particular organ system, or do you find it's really random?
I don't think there's no hard and fast rules. That's why I call it the master of disguise, because it can present. You could get hair loss and joint pains and palpitations. You could get. Yeah. I mean, you just don't know. I mean, that's not to say if you have some of these symptoms, if you have chest pain and palpitations, I am not saying this is the menopause and you must not have it investigated. Absolutely no way. Anybody with those kind of symptoms or bowel symptoms or anything that has a kind of red flag in it needs investigating to exclude other causes. But it's those women that have been sent to cardiologists or neurologists or gastroenterologists and no cause has been found, and they're often just sent away, and their symptoms persist.
Yeah.
And they're at a loss, and that's when it's very useful to think of. I mean, it's always useful to think of the menopause, but that's when you think, 1 minute, this is not.
I mean, it is fascinating there when you're thinking, certainly, I mean, this week I'm talking a lot about digestive health and IBS, and I'm convinced I see more women at sort of mid to late 40s for IBS, and I'm never really sure, is that a direct correlation, or is it that women are kind of taking a breather and having a full MOT and dealing with everything that's been bothering them for ages? But you can easily see, and I'm just thinking of several of my closest friends who are bright women, really, at the top of their game, who were struggling for a long time with these gradually progressing symptoms. One in particular I'm thinking of, her name's Libby, and she was, just becoming as if she didn't care. She was just lost all her drive, all her mojo, and it was absolutely not in her character. And it took us actually quite a few months, and we were away on holiday together one day, and we just had a walk, and we were talking about, you know, why she was so fed up.
Yeah.
And it suddenly dawned on me, you know, and blooming hell, I ought to know. And I sort of said, I think this is menopause, you know. And actually, of course, then we took her up, we got her sorted out, and you know, immediately things responded. But I think, as you say, the biggest frustration that I've been hearing this week as women have been sending in questions is either that they feel that they have to be so stoical and just battle through this, or that they have approached their GP who has kind of really not been too sure what to do. And that's no disrespect to our GP colleagues, but I think unless it's something that you can measure in a blood test, this actually takes a bit of time to work it out. And could you explain to us why just taking a blood test for this is not really the way to go anymore?
So if you're over the age of 45, the UK guidelines are that you do not need any blood tests to diagnose the menopause. So if it looks like it's pretty, you know, barn door, and you're over the age of 45 and you've got menopausal symptoms, then you can start treatment with HRT or whatever your treatment of choice is without diagnosing on blood tests, because the chances are you are hypoestrogenic anyway. Under the age of 45, they do suggest taking a blood test, and you look for FSH, which is the hormone that the brain pumps out to get your ovaries going into gear to start developing a follicle, which which releases an egg. Because hormone levels fluctuate so much during the perimenopause, a normal blood test does not exclude that your symptoms coming from low estrogen. And of course you can do estrogen levels as well, but they also fluctuate enormously. So if you have a woman who's under the age of 45 with a very high FSH and a low estrogen, brilliant, you've got your answer, it's there for you in black and white, and you can treat as such. But if those blood tests are normal, it does not mean that you are not perimenopausal.
Okay.
And that's why GPs really struggle, and understandably so. You know, they struggle to then think, you know, to use the menopause or the perimenopause as a reason to starting estrogen, because they think it might be so. And other things should be looked at. I'm not saying, you know, I would always do a full bank of investigations, but if everything else is normal, then it is very reasonable to trial estrogen therapy.
And again, let's just take one more step back from that. So you've got your GP that is aware that a blood test isn't necessarily the best thing to do, and you're sitting there as the woman experiencing this, trying to explain what's going on. I don't know what you think about this. I'm a real advocate for diaries, symptom diaries. And I would imagine it might be really helpful for a woman to go in with a completed diary to explain, look, this wasn't happening to me a year ago, and now this is happening every day. This happens quite regularly. Is that, would you agree?
Absolutely. I mean, symptom diaries they're so helpful, because one of the other things that can worsen during the perimenopause is PMS. And so if you have a history in front of you where your PMS is clearly getting so much worse, that again is an indicator that it's a kind of perimenopausal worsening of PMS. And you can treat both together. I mean, the treatment's similar. So
okay. So because again, I'm going to come back to a question we've got at the moment about estrogen therapy, but in a similar vein to the IBS I was talking about, I will always use a diary for that to help with that as well. And incidentally, if you want some help with a diary, just direct message me. I've got a menopause symptom diary. I've got an irritable bowel symptom diary that I will gladly send to you, just as a starter for you. So then, right, so now we've got our diary, and our doctor is beginning to come onto the side that maybe something's going on, but you feel that your doctor isn't really that up to date with menopause. How would somebody get access to see?
They're just frozen. Oh, Nigel, you've gone. You've gone. You're back.
Naomi? Okay.
No, yeah, you're spinning. You're spinning.
Okay.
Yeah.
You
I don't know
were
why, 'cause it
too.
was perfect. I don't know. It was perfect.
Yeah,
And
me too. I've stopped spinning. You've
yeah,
stopped spinning. Yeah, you can hear me now.
yeah,
Right.
yeah.
Okay, let's
That's great.
keep going.
Okay.
So, because obviously women can talk to us online, but if you want to be able to see a doctor who specializes and really has trained in menopause, there are plenty of them around, aren't there?
There are. I mean, you can. So what I would say first is you can get help from your GP, but there are a lot of brilliant GPs out there. And what a lot of women have done have taken in. So on my Instagram feed, there is like what to ask your GP, and you just go and show them the post. It's really easy, and then that's how you can access care.
And that's actually up on your feed. People can just access that
on my Instagram feed. Yeah,
brilliant.
Some women prefer to see somebody who's got a specialist interest, or or they haven't had any luck. In which case, it's very easy to book an appointment online. It depends on whether there's funding, how quickly they want to be seen. There are also NHS clinics, but the waiting list is, especially with COVID, it's about 9 months to be seen.
Right. Okay. So I'm imagining then, just again, what would be the oldest you would expect perimenopause symptoms to be seen in someone?
Well, I mean, menopause symptoms can just continue on. They can go on until your 80s and 90s. It would be unusual for a woman to be kind of in her mid 50s and not have an ovarian decline. I mean, it would be practically impossible. You can still have regular periods well into your 50s,
Sure.
and you may have no symptoms.
Somebody also asked earlier on that they were having symptoms, and their periods were a bit erratic, and their mum had told them that they didn't need to worry, they couldn't get pregnant anymore.
No, that is not the case. That is not the case. Yeah, if you're over the age of 50 and your periods stop, you need to wait a year before you're considered to not have any chance of pregnancy. And if you're under the age of 50, then you need to wait 2 years. And if you're over the age of 55 and you're still having periods, you can be assumed to not require contraception over the age of 55.
Right. So if someone was, say, taking the pill, or they'd got Mirena or something like that, and they were beginning to experience some symptoms, would the pill or the Mirena mask those symptoms? Should they carry on with their contraception? What do they do?
The combined pill will mask symptoms because it gives you estrogen. So so if you're taking the combined pill in a 3-week on, 1 week off regime, you may notice symptoms in your week off, in the week that you're not taking the estrogen pills. If you have a Mirena, then you probably won't notice periods changing, but you may well notice your systemic changes. So you may well get hot flushes or night sweats, and the other more systemic menopause symptoms.
So
But then
again,
you can keep a
probably a
Mirena
diary.
if you want HRT.
Yeah.
Yeah, absolutely. So diaries are you really so for the week off, if you're taking the combined pill and you have a week off and you don't feel very good, and then you start taking the pills again, you feel better. That could ring ring alarm bells.
Okay.
Definitely.
And then I think something else. So someone else was speaking in the week and saying they really didn't have any physical symptoms, but their head just felt like a kind of paper bag full of air. They couldn't remember things. They couldn't concentrate. They were irritable. They were just like in another place. Is that's something quite common?
Absolutely. Yeah. I mean, it affects your brain. It affects your neurotransmitters. And so, the low estrogen. And so absolutely,
Yeah.
It's just another manifestation of low estrogen. Yeah, brain fog. It's whether you've got the brain fog, whether you've got the anxiety, whether you've got it's tearfulness, can't cope, overwhelmed, all of those. Yeah, those are
Cracking questions just come up there. So we're always talking about hormones, plural.
Yeah.
But we seem to home in so much on estrogen. So
Yes.
what about progesterone? What about testosterone? Tell us a bit about those.
So the majority, as you age, your ovaries produce estrogen and testosterone, and the production decreases in a very kind of fluctuating way. So yes, a lot of the symptoms are down to a decrease in estrogen. There is also you produce testosterone elsewhere, but you will also overall produce less testosterone. And a lot of women find that even after replacing their estrogen, there is still something, they still feel like there is something missing. And testosterone can be the key. So testosterone replacement is done, and we would normally consider it in women who have had estrogen replacement, who still feel like there is something missing, like a lack of oomph, a lack of energy, a lack of joie de vivre, libido, just a kind of general strength, in which case testosterone would be a good thought. The problem is that there is no licensed female product available in the UK for testosterone replacement. There are male products available on the NHS, but there is no female product available on the NHS. There is a product available privately that is designed for women, that is imported from Australia. It's very good. It's called Androfem, which doctors can prescribe privately. It works out about 80p a day, but you probably struggle. You may well struggle to get your GP to prescribe the male products on the NHS, because even though GPs can prescribe them, a massive red alert box comes up when you try to, because it says this is designed for male use. You're prescribing this for a woman, and so you prescribe it in female doses. But it really gives you, as a GP trying to prescribe it, it really gives you the heebie-jeebies, because you're basically being told that what you're trying to do is not allowed. So women often struggle with testosterone from GPs, which is another reason that I need to go to a specialist. Progesterone can help with sleep and calming. So some women are very progesterone sensitive and it makes them very anxious, but in other women it can help with sleep. And it also helps control bleeding, and you need it for to protect the endometrium, the lining of the uterus, from giving estrogen. So it's required if you have a uterus, but that's why we give it at night. So if you're giving estrogen and progesterone separately, then progesterone is prescribed at night because it can help with sleep. But it's not normally the culprit for the hot flushes, the night sweats, the brain symptoms, and the big kind of estrogen deficiency symptoms. Does that make
So
sense?
totally, yeah. So I mean, again, this is where I mean, I always say to
You're just breaking up again.
have we lost you?
Nigel,
I'm
I
going to
hear
keep
you.
talking and see if
Yeah.
Naomi comes in. Right. So, yeah, I'll often see a woman who's concerned about weight gain that is occurring alongside these symptoms. And very often, oh, great. Very often, they'll say to me, you know, so I've been to see my my doctor and I've started on HRT, and I'll say, great, how are you feeling? And it might be 3 months in, and they say, well, some of it's a lot better, but it's still not quite right. And I'll often be saying, you need to go back, because you, after about 3 months, things should be settling into a new norm for you. And this is going to be the time now where it can be fine-tuned and tweaked
Absolutely.
to match exactly what's going on. And it sounds like your knowledge there of those other hormones is where a lot of that tweaking would happen.
Yes, yeah. So it's because, so if you have a woman in their kind of mid to late 40s, they may come to you fairly early on, and they may just need a bit of an estrogen top up as their symptoms are just starting. By the time they get to 50, their ovaries really probably won't be producing a huge amount, and so they then might find that their requirements increase. And then as you go through your 50s into your 60s, or however long you choose to stay on it, your requirements then decrease again. So there, it's a constant change. And that's why we
Right.
recommend an annual review, because your requirements change, and it doesn't mean that you're doing anything wrong or that there's something. It just is that you have, you know, your requirements and your metabolism changes. So
It sounds to
yes.
me like, just like, I don't know, I've had the same guys look after my car for years, and they know the car, and they, you know, they take care of it as it gets older. Sounds to me like you really need a doctor with you all the way through this journey to keep reviewing it for you, and also reviewing it as your life is changing. You know, throughout this period, you might well find that, you know, other aspects of your life, not to do with your health, change, and you need your hormone therapy to change accordingly.
It's, I mean, the British Menopause Society recommend an annual review, and I think they do that for a reason, because things change. You know,
Yeah.
it's, you can't go to the doctor once for your entire life and expect that one consultation covers all of your current and future, you know, health
Yeah.
issues. It's but you see it all the time. You have people who are very stable, and then all of a sudden, you know, it's like, oh, something's come back, or something's changed, or my hot flushes are back, or, you know, I've got this new symptom. And
Mm.
so that's why it does require kind of monitoring and tweaking, and patients not thinking that there's suddenly a failure when things don't, you know, they often come in and they say, I've just had 9 months of feeling great. Why has it all gone wrong? What am I doing? It's not that they're doing anything or not doing anything. It's just that things change.
Yeah.
Um,
Yeah. I mean, I think all of any hormone related condition changes over time. Look at diabetes, you know, where we're
yes,
looking at insulin.
absolutely.
Somebody's type
Thyroid,
2 diabetes changes dramatically over the course of 10 years or so.
yes.
This is going to change as well. There was a question, you take a breather for a second, Naomi, because there was a question there asking about estrogen containing foods and whether those are
Yeah.
a good treatment for this. So that's kind of my area, I guess. Well, really the highest concentration of plant or phytoestrogens that we see tend to be in soya foods. And there has been over the years loads of interest in whether soya could be a natural sort of food-based HRT. The reality is no. it can't. We know that in younger women, so perhaps in their mid 40s, whose predominant symptom is hot flushes, a high intake of soya, which contains these plant estrogens, can reduce the severity and the frequency of their flushes, but it won't do any more than that. And when we talk about a high intake, we'd be looking at 26 grams of soya protein every day, no days off. And that would literally mean soya milk at breakfast, a soya yogurt at mid-morning, a sandwich made with soya and linseed bread at lunchtime. Dinner, you would need to have edamame beans or tofu, and you'd probably need another soya milky drink at the end of the evening. Now, I really don't want to poo-poo the idea, but my honest thought is, if you could be bothered to do all of that, your symptoms aren't that bad. Do you know what I mean? It really is. This idea
But also,
that
if you're
treating...
prepared to, you're basically taking the same estrogen, whether you take it like that, which is a massive effort, or you just take it via HRT, you know, which is much more straightforward, and it's derived from the same product anyway. So
I mean, another way to look at this for me, I think, you know, we can talk a little bit about the pros and cons of HRT, and I think we probably ought to do a whole session on HRT.
Yeah, I saw somebody had a question about side effects of estrogen. So we you know, to go through the risks and benefits, that would probably be better in its own slot,
in its own session. But the one thing I would say is, you know, HRT is natural. First of all,
yes,
it's, you know, it is a perfectly natural product. If you were coming to see me and you had iron deficiency anemia that left you feeling ghastly, and you weren't able to obtain iron from your diet, you would take a supplement. That's all this is you are supplementing your estrogen. Which,
if you're a diabetic, you take insulin. If you're hypothyroid, you take thyroxine. It's
you know, and I think we've also, you know, it's a good reminder. I know you and I do these talks a lot, and it seems to us sometimes we're repeating ourselves a lot, but something I think that always strikes a chord with women is you are going to spend just as long as a menopausal woman as you did in your fertile years. You know, you're going to live well into your 80s, maybe your 90s and beyond now. That's a 40-50 year period of being menopausal. You blooming well might as well make sure those are good quality years.
Yeah, which is just so different to how it was a couple of 100 years ago, isn't it? Where you would be expected to die in your, you know, late 30s, early 40s.
Exactly.
An issue because there was nobody around.
Yeah, totally. Just back, this is a bit of a theory and that we might be able to explore. So this link with more women experiencing IBS type symptoms, so abdominal pain, bloating, just general soreness around the tummy, a change from constipation, diarrhea, fluctuating bowel movements. Do you think it could be a reasonable assumption that possibly the hormones that might be involved in giving you cramps and abdominal pain linked with PMS could potentially be making you more sensitive to the pains and discomfort that you're experiencing at IBS with your digestive health? Do you think that could be?
Yeah, it's an interesting theory, isn't it? Because you've got hormone receptors everywhere, haven't you? And so if you've got if you've got declining or fluctuating hormone levels, then it would make perfect sense that would have definitely have an impact on bowel function as well, wouldn't it? It makes perfect sense.
Yeah.
I don't know if any studies on.
No, I don't. But I just wonder if that is partly what's involved. So let's think then, if somebody's watching this and none of this has started for them, but they've got sisters and a mum who are in the middle of it or have gone through it. Is it likely that you might follow the same pattern as your siblings or your mother?
Things do run in families, don't they? And so I think if you come from a family where the women have gone through menopause early, particularly if they've gone through it very early, then it does tend to follow suit, but not always. So,
Right.
you know, if you have a woman come to you in their late 30s and they say, I think something's going on. Especially if they say, I'm still having regular periods, but I've got these new symptoms, and yet my mum went through a menopause in her early 40s and my sister did, and my GP won't listen because I'm still having these regular periods. You've got to think that it's the likely diagnosis. So it tends to, it's not absolutely hard and fast, but definitely tends to, yeah.
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 Okay. And I guess then what I also...
We've got it for our half an hour.
Oh, right. What I would like then, sorry, I'm so engrossed. What I would like then, for us to finish off, is sort of 2 take-home messages for folks watching, if they begin to think that something's going on.
I think probably the first take-home message is that you can definitely be perimenopausal or suffering from low estrogen levels, even if you are having regular periods. And that's I think that's so important, because it's the things that mask, you know, it's the red herrings that kind of mask the truth, that are the dangerous things, because those are the obstacles to people seeking help, aren't they?
Yeah.
And the other thing is the blood test. So again, if you have normal blood tests, but you have those symptoms, it does not necessarily mean that you are not perimenopausal, you are not suffering from estrogen deficiency, and that supplementing the estrogen would help.
Great.
Those are probably my 2.
Yeah, most definitely. Yeah, I mean, certainly I would say, do not for 1 second think you're going balmy, because you are not. This is so common. And do not also suffer in silence. You know, if you feel like you've hit a brick wall when you first reach out for help, reach out somewhere else. I think a really, really useful thing is to get that information to what to ask, how to prepare for a session with your GP. So you can go to Dr. Menopause Care, and it's all on your homepage, is it?
Yeah, so my information is on it's all on the grid. It's very
fine.
easy.
Okay, and if you would like those diaries, the menopause symptom diaries or the IBS symptom diaries, message me, or you can go to my Facebook page, which is Harley Street at Home, and you can download all of those from there. But I think, you know, really, there is masses of help out there. Do not suffer in silence. Yeah. We will be back in a couple of weeks.
So helpful, isn't it? Like people respond to replies on posts, and everybody's a team. Everyone can tend to work together. There is a huge, well, I'm not saying a huge community, but a very supportive community. Right? I mean, if you're watching this, then you're going to be aware of it. But do post, do comment, and say how you're feeling, and 100 people will flock to help. It's
Couldn't agree more.
Really supportive community.
And we are going to come back and we'll do a special session around HRT. And I expect we'll do another special session, which we do a lot, around weight. But we will be back talking to you about menopause, hormonal health. And I'm sorry we've run over, but thanks so much for joining us.
My phone's about to die. I'm just conscious it's just going to
go. Go. Lovely to see you. Lovely to see all of you joining us. Thank you so much. And we'll see you very soon.
See you soon.
Bye.
Bye.